By the end of this video, you will have mastered the fractures. This will help enhance your score for step 2 CK. A common question on the boards is the difference between the anterior and posterior shoulder dislocation. You will have a patient that comes with shoulder pain after an accident with a normal radiography of the shoulder. They will ask you if they need further radiographic tests or if observance is enough. This question tries to trick you in thinking that the patient has no problem. However, traumatic injuries are associated with posterior shoulder dislocation. This dislocation can be diagnosed only with an apical radiography. On the lateral and anteroposterior radiography, this type of condition is unseen. When the patient will come at the ED, he will present with an externally rotated and easily abducted arm if he has anterior shoulder dislocation. If he has a posterior shoulder dislocation, his presentation will include internal rotation and adduction. As stated in the question stem, an anterior dislocation is visible with an anteroposterior radiography. On the other hand, the posterior dislocation can be seen only on the apical radiography. The treatment for both types of shoulder dislocation is represented by a shoulder sling. Another question for step 2 CK is what motor deficit will be present in a patient that has a radiography with an anterior shoulder dislocation. The answer is represented by the deltoid muscle. During the anterior shoulder dislocation, the axillary nerve can be injured. Thus, its sensitive territory around the deltoid muscle and at the level of the shoulder, as well as its motor innervation to the deltoid, will be affected. Another trick seen in the NBMEs is the difference between falling on an outstretched hand. There are two types of fracture that occur with this type of fall. If the hand is pronated when the patient falls, there will be a Monteggia fracture. If the fall is with a dorsiflexed hand, a Colles fracture is more frequent. Another detail seen in the case of the Colles fracture is the fact that usually we have elderly with osteoporosis or children. In contrast, Monteggia is more frequent in adults. Both are diagnosed with radiography. However, in the case of Colles fracture, we have a posteriorly displaced radius and wrist, while the radiography on the Monteggia fracture will show a proximal ulnar fracture. The treatment is also different. A more invasive treatment is practiced in the case of Monteggia fracture. It includes an open reduction and internal fixation, followed by a closed reduction of the radial head subluxation. It is common that the proximal fracture of the ulna in Monteggia fracture is followed by a radial head subluxation. The treatment for Colles fracture is represented by closed reduction with long arm casting. Another fracture of the forearm is represented by Galeazzi fracture. The history of the patient includes a blow to the radius, Thus, on the radiography required for diagnosis, there is a fracture of the distal radius shaft. The treatment is as invasive as in the case of Monteggia fracture. The patient will receive an open reduction with internal fixation. The adjuvant therapy is represented by casting in supination. The humeral fracture has a typical presentation. The patient has the wrist dropped. He is unable to extend his thumb. The diagnosis is made with a radiography which shows usually a midshaft fracture of the humerus. The treatment can be a coaptation splint with sling, or one of the answers on the questions might be a cast. Commonly, on step 1, you will be asked what nerve is injured when there's a midshaft fracture. Through the radial groove at the level of the midshaft, we have the radial nerve that will get injured, and thus the patient will be unable to extend his wrist and his fingers. One trick question on the boards is a patient with a midshaft fracture. They will tell you that he is unable to extend his wrist. Then they'll find a way to ask you if he is able to extend his forearm. The correct answer is that the triceps innervation given by the radial nerve occurs before the radial nerve enters the radial groove. Therefore, the patient can still extend his forearm. A rare case seen on NBMEs is the nightstick fracture. The history is typically a person who, protecting from a blow, got a blow to his ulna. On the radiography we have a fracture of the ulna, and the treatment is either a cast if the fracture is non-displaced, or an open reduction with internal fixation if there is displacement with the ulnar fracture. If you like this video and you'd like to see more educational videos, subscribe to the channel.